Okay. Welcome to the governing body of Northamptonshire CCG. This is the 17th of August. Thank you everybody for coming this afternoon. We have a number of apologies this afternoon that people who are unable to come. Mitten Ribelia, Chris Ellis, Neil is unable to come. We have Emma follows in his place. Julie Curtis is unable to come, and Julie Lemmy is here this afternoon. I believe we also have Itai Matambike, the Medical Director of NHFT, who is joining us this afternoon, and he is extremely welcome. And that has become something we are now doing moving forwards. We will have medical directors from our local trusts in order to give additional clinical input to our governing body. So they are all extremely welcome. Are there any on-call directors present here this afternoon? Nope, perfect. Are there any declarations of interest relating to items on the agenda that we need to particularly be aware of this afternoon? Nope, I'm seeing shaking heads, that's good. The first thing I wanted to go to was to the minutes of the previous meeting, which was dated on the 15th of June. I'm going to go through that for accuracy to start with. So if we just, I'm going to use the pages on the pack for all of the meeting this afternoon. So if we go through page 4, page 5, 6, 7, 8, 9, 10, 11, 12 and 13. Is everybody happy that there was an accurate representation of the meeting that took place last time? Are there any matters arising that anybody's aware of that are not on the agenda or on the action log? Okay, and then we've got the action log. We've got 2 items that are green on the action log, and so those have been completed. So the next item that is on the agenda is the Chair and the Chief Exec report. I'm going to assume that that has been read. Toby, is there anything you particularly want to draw people's attention to before we then open that for questions?
Thank you, Joe. Just one point from me, mindful of the length of today's agenda and the amount of things that are covered elsewhere. Just to note, the paper makes reference to the introduction of the CCG's internal Agile working policy. That's something that many of you will be aware we've been putting in place, like all organisations and sectors, thinking about how people return back in, particularly to office-based working. Worth noting for colleagues who might not have been in and around, particularly our HQ at Francis Crick House over recent months, that we have now started to move quite a number of people actually coming back in on a sort of 2 or 3 day a week basis. And I just wanted to say it's been lovely to see people. And the number of kind of conversations I've just had catching up with members of staff and teams, some of whom we haven't been in the same spaces for the best part of 18 months, and some of them meeting together as well. So looking out the window from the office here today, I can see various colleagues kind of appropriately placed across the building. So those, and it might be relevant, Joe, when we touch later on the subsequent item on corporate working arrangements, there's something for me about how in a kind of phased and appropriate way do we start to reintroduce some of those elements as well. But I just wanted to thank colleagues and staff. As of last week, all of our directors are next tier down, so they're deputies and assistant directors, that we took a policy position for them all to start coming back at least 3 days a week from last Monday, and we've started seeing other staff taking the opportunity on the back of that to say it feels okay, we're comfortable with that, let's start to move in that direction. So clearly still being cautious, clearly still doing things you'd expect, like wearing face masks and moving around the building in communal spaces, but good to start to see a little element of that returning, and some of the kind of conversations and team conversations that you just pick up in that way. Thanks, Joe. That was all I wanted to draw attention to.
Thank you. Any other questions or queries from governing body on any of the other elements of the report? Okay, thank you. We have not received any questions from members of the public for this meeting. They are still welcome to do so, but we have not received any on this occasion. So we're going to move on to item 8, which is the COVID-19 position. Over to you, Lucy.
Thank you. Apologies, I was in the mid-sneeze. So from a point of view of an update for the national position first, England, very similarly to the East Midlands, has started to plateau. There are sort of peaks and troughs on a day-to-day basis, but overall we're not gaining or losing any ground. The England percentage positivity at the moment is 8.4%, so that's increased by 5% in the last 7 days. And the all-age case rate is 306.4 cases per 100,000 population as a rolling 7-day average. That's increased by 6.5% in the last 7 days. The East Midlands has a higher percentage positivity. There are a number of areas in the East Midlands that have featured on the Chief Medical Officer's watch list for some time. I'm pleased to say none of those areas have referenced, obviously, the 2 new unitary councils, although we do know that Kettering's rate as of today is higher than we would want, but we do understand the epidemiology behind that. The East Midlands percentage positivity is 10.7%, which has gone up by 4.9% in the last 7 days. The all-age case rate is higher than the national rate at 354.8, which is a 6.2% increase in the last 7 days. From a point of view of the old borough and district areas, we've got, as we always have, a range of case rates. Kettering, as I mentioned, is at the top and has increased in the last couple of days. It's at 399.2. We have got a couple of challenging outbreaks there, so we are aware of some of the drivers for that. But one of the things to note, obviously, is we're keeping an eye on younger age groups, as they do tend to still be sort of the age group 10 to 19 and 20 to 29 that are most affected. And obviously we're keeping an eye on, in particular, in the over 60s case rates, where we have seen some increases in areas such as South Northamptonshire in the last 7 days. So from a point of view of the lowest case rate at the moment is East Northamptonshire at 245 per 100,000. So again, an area that we're pleased with the progress of, but we are talking about small numbers, so we can see an outbreak or two in that position change. Our environmental health officers are obviously supporting businesses in particular at the moment as everything is reopened to ensure that they are happy with the support that they're getting. They understand all the changes to restrictions. They've got the resources that we're able to provide that obviously encourage people to continue to do things like wear face masks where it's appropriate in small spaces, to lateral flow test if they're going out to a club or a bar, for example. And also we're preparing for the return to school. Again, we're just waiting on some of the final guidance, but there will be a spate of testing before children return to school, but there won't be an ongoing testing requirement. So some of the changes over the last couple of weeks, obviously we do expect to see again an increase in case rates as we have done with any other change, but we're confident that the contact tracing, the testing and the vaccination availability locally will help us obviously counter any potential increases.
Thank you, Lucy. A very comprehensive and helpful report. And obviously alongside that, we have the vaccination programme that continues as well. And that is also critically important. And if you're listening and you haven't been vaccinated, please could you get yourself vaccinated? Lots of opportunities and places that you can find out where to get that, or call 119 or look at the council websites. Any questions or queries? Graham?
Yes, just a quick question for Lucy on the stats. Bev forwarded the sort of chair's report, which had some COVID stats in there, and I suppose I was a little bit surprised to see that the #1 place for outbreaks was still care homes. I felt we were all over this and really put in the most stringent measures. Is there any particular reason or explanation? Is it the visitors profile, or what do you think's happening there?
So from a point of view of the frequency of outbreaks in care homes, you've got to remember that the definition of an outbreak is 2 or more cases linked by time or place. And obviously in all of our settings where we have patients or residents, we are still asking all staff to lateral flow test on a regular basis. And indeed, we have been lateral flow testing a lot of the residents as well. So we're proactively case finding in those circumstances. And I'm very pleased to say that actually, although we are seeing more frequent outbreaks in care homes rather than any other setting, it's still a low number. They still are very small when we do find them. And as I said, it is because they're actually proactively swabbing. So it is mitigating any risk of residents being affected or that outbreak actually growing in significance. Our larger outbreaks do still tend to be in our workplaces, obviously less so schools while they've closed, but no doubt we will see those as well when they return. But I have no concerns over the management of our care homes at this point in time.
That's great, thank you.
Thank you, Lucy. Ange?
Yeah, I was just going to reiterate what Lucy's just said, Graham. Through the joint work we do at the council, we have a tracker and we can see all of the outbreaks, and Northamptonshire is not an outlier. So just to be assured on that, and we also speak so regularly with our care homes in terms of what they're doing around prevention. So just to give you some reassurance, Graham, it's always on our radar and it's always a topic of discussion. Thank you.
Toby.
Thanks, Joe. Just worth noting, and building on Lucy's update, that the Local Resilience Forum across Northamptonshire, that's the multi-agency partnership that involves police, fire, local authorities, health and so on, has carried on constantly reviewing where we are as a county. I chaired the latest meeting of that group, I think it was Thursday last week from memory, and we looked at the stats, we looked at the numbers, we also looked at things like acute hospital inpatient positions, which has always been one of those barometers of how much pressure is the NHS under. Locally at the moment we've got sort of 55 cases of COVID positive inpatients in the 2 acute hospitals, but I think only kind of a 2 or 3 that are actually in terms of ITU or HDU dependent. So looking at all of that in the round, the Local Resilience Forum concluded we didn't need to step up further measures that were multi-agency at this point, and was content for health and care services to continue to work through their response, the management with settings and the approach around vaccination programme. So I just wanted board to be kind of reassured that there is a active process there of constant ongoing review informed by the evidence and the data that Lucy's just described, but not sensing at the moment a need for a change in kind of escalation or response across the county at the moment. Thanks, Chair.
Thank you. And I think it is something that we will continue to update governing body on. We are still absolutely in the middle of a pandemic, as well as all of the other things that are going on. Hopefully it won't be something that we have to report on forever, but certainly at this point, it is a really key issue for our system. So thank you very much for your update. Next item on the agenda is item 9, the People and Organisational Development Update. And over to you, Sarah.
Thank you, Jo. So we've brought a paper today, which I'll take as read, which just works through a summary largely of the people and OD related activities from a CCG point of view this year. We wanted to make sure that you were cited not only on some of the output from the staff survey and some of the actions we've taken, but more broadly on some of the people and OD work that we've been doing. You'll note, I hope, through the report, a real focus on engagement, on co-creation where possible with colleagues across the CCG, the listening sessions. So we've appended here the output from some of the listening work that we've done in terms of things we've heard and actions taken. And then the second section of the paper looks in a bit more detail at the role of wellbeing guardian for the CCG. The role is outlined in the paper, so I won't go through it again, but both NHS England and Improvement and Health Education England recommend that we have a nominated wellbeing guardian on the CCG board. They recommend that for all NHS organisations, actually not just for CCGs. And so this report suggests that Bev Messenger takes on that role for us as our current deputy chair. And works with me as people and OD lead, and also I'm currently our Freedom to Speak Up guardian as well, and that we work together to make sure that that role of wellbeing takes the importance it should from a governing body point of view. So that's the recommendation in the report, Chair. I'll stop there and take any questions or comments. Thank you.
Thank you. And just slight amendment to the actual agenda. Obviously, the element of the wellbeing guardian is an item for approval, and when I take that item, Bev is not allowed to vote. But I don't believe there's any problem with her being present for the conversation that we need to have. So she's going to stay within the room at this point, but will not be able to vote on her own appointment. The rest of us will need to vote on that. Any comments, questions? I think the one thing I'd like to remark on at this point is how hard everybody has worked, what a challenging time this has been, and how impressed I've been with really everybody within the organisation. It has been a really testing time, and I think it is so important that we look after all of our staff and obviously everybody that's working within the system, but I think this is very much the focus on our staff. And I'd like to thank them for everything they've done. Any questions or comments on this one? Andrew?
Yeah, it's just a quick one to sort of make sure that we have this as a formal baton going into ICS. I'd hate for the work to get lost as we move into a new organisation. So I think we need to formalise a baton that needs passing over into the new organisation to ensure continuation. And I guess that there's also a question around how we look at the outputs in terms of employee engagement, etc., into a new system, into a new structure. I'd be keen not to lose the progress that we've made as it gets swallowed into a different structure. So I'm not sure how we'll do that, but I think it's worth thinking about.
Yep, I think that is an entirely reasonable suggestion and absolutely critically important. There is so much that we need to be doing now and also to transfer into the future as well. So I think that is critically important. Sarah.
Thank you, Jo. Just to say, Andrew, it is already a plank of the HR and OD transition plan from a CCG handover point of view. So we're working through not just the kind of transactional handover from an HR point of view, but also how organisational development works, sits in homes. So just to give you some assurance that that's covered in one of the transition programme work streams currently.
Thank you. Any other comments or questions? And in particular, obviously, Bev, over to you, Bev.
Thanks, Jo. Apologies for being late. I hope you got my message to say I was going to be a few minutes late. Just to confirm, you know, what Sarah said about it being in the transition plan, but I'd like to see us take the opportunity as and when the new infrastructure of subcommittees for the ICS is developed, that we do what we've talked about here about make that a truly sort of remuneration and people committee so that it has its statutory responsibilities, but I don't think there's any reason why we can't broaden that out to make sure that the OD angle and the people and well-being is completely locked into that from a governance point of view, which will help the baton passing that you've described.
Thank you, Bev. Ali?
I think there's an opportunity to make sure that all the wellbeing guardians across all organisations come together and then link into the people board. So there's a collective voice. So I'm assuming that's going to happen in terms of the ICS as it progresses. But Bev, that will also house you within the broader conversations then, as well as the baton for the CCG.
On the assumption that, of course, we vote her into that position.
Which that is very true. That is very true. Yes.
We will be doing potentially in a moment, but I wouldn't want to overly anticipate that aspect of it.
And on that point, seriously, I mean, I can completely understand why this is sort of, you know, mandated as being a key responsibility in the same way freedom to speak up is, but I certainly don't see this as being my only responsibility should I be appointed. This is very much every board member's role and responsibility in my view. You know, there's a figurehead and the focal point, but it's a shared responsibility, or else actually that to me goes against the whole ethos of it in the first place, that it's only locked into one person. We all need to be responsible for that.
Yeah, I couldn't agree more. Any other comments, queries, questions or thoughts on this particular item? So obviously we are noting the first part of the paper. The second part of the paper, just reminding everybody, this is number 9. If you approve the nomination of Bev as the Wellbeing Guardian, then could you put the number 9 and the word approve in the chat, please? There will be no prizes this afternoon for being the first to respond, although I'm grateful when people do respond in a speedy manner. Thank you. I think we have. There we go. That's helpful. Thank you. So that item is approved. The next item on the agenda is Lucy with our public health report, which is a wide and varied report. Obviously, we have read it. Lucy, tell us the particular areas that you'd like to draw our attention to.
Thank you, Jo. So there's just 3 things I'd like to draw people's attention to, please. As you say, I'll take it as read, so I won't go into detail, but obviously I'm sure people will join me very pleased and to see that our Supporting Independence programme is back offering face-to-face appointments. So that is a wide range of wellbeing advisors with wide and varied backgrounds who support people who are needing a little bit more than just universal help, but who wouldn't be eligible for something like adult social care. So they're they're able to provide support, befriending services, and one of the other things they obviously do is provide things like get up and go sessions, which help people gain confidence or retain confidence with regards to mobility, provide them with some support around facilitated activities, but also give them opportunity to socialise. So it's nice to see those sessions back up and running amongst the other sort of more generic wellbeing and supporting independence programme face-to-face sessions. So obviously encouraging our primary care colleagues to be referring back into that service. The other thing that from a provider perspective I'm really pleased to see is starting to look more so at face-to-face delivery as our adult learning service. So that sits within public health, and it has a Learn to Be section, which is very much focused on people's well-being and developing sort of recovery and support services and self-help services where people are recovering from mental health difficulties. So again, an opportunity to socialise, some extraordinarily experienced lecturers who are able to support people on an individual basis with particular needs. But it is also, as I said, an opportunity for people to gain further skills, and obviously a lot of people looking to return to work, so able to support some of that transition too. And lastly, the campaign around safer sleeping is another thing I wanted to just draw people's attention to. Sadly, over the period of the pandemic, we did see a small number of deaths due to co-sleeping. And obviously any death that is potentially preventable by providing the most safest sleeping environment that we can for our babies locally is anything something that we want to do. So planning for a safer sleep every sleep is a campaign that I would ask you to help promote. It just provides tips and advice with regards to what the best practice is around providing your baby with a safe sleeping environment. Obviously avoiding alcohol and drug use if you are obviously looking after a child or sleeping, but again it just refers again to things like the Lullaby Trusts, who have got a range of resources and information about, as I said, providing information. People can pass it on to friends, to colleagues, to family members, so please do spread that campaign widely. Obviously we would hate to see any further deaths that were potentially preventable through things like co-sleeping, so the wider we can spread the word on best practice, the better, please.
Thank you, Lucy. I'd like to notice particularly the strength of the branding for the public health messages and how widely those have been spread on social media, and I think that has been a really useful approach, but absolutely the wider we can spread these messages, the better. Any questions or queries for Lucy on the public health report? Philip?
Yes, Lucy, I'm not sure if it is your area or not, but one thing that has been raised with me, which I think is public health, is access to contraception services, particularly for long-acting contraception throughout the county. And I just wondering if there's any, if that's been raised with you, or anything which we can do anything about to help.
So no, it's not been raised with me at all. We haven't had any complaints with regards access. Obviously, access is primarily through general practice. We do have some outreach facilities that are contracted and are provided in various other settings, but it is primarily delivered through primary care. The other thing, obviously, that people can do is speak to their pharmacy if they need sort of the morning after pill. So again, pharmacies have remained open, so we haven't had any access complaints with regards to accessing that kind of service as well. But Philip, if you've got anything in particular that you want to give me an example of, please do contact me via email and we can look into that. Obviously, we're always keen to hear if people are having trouble, to make sure that we can obviously provide the service as and when it's needed. It's an important service, and it is something that obviously people need very often quite rapid access to.
Okay, I'll drop you a line, Lucy.
Thank you. Toby?
Thanks, Joe. I thought we ought to mark the moment, Lucy, on social prescribing, which is covered within the paper. Spring, I think I'm right in saying, is now live. I've clicked on the link that's included within the paper. The website's all up, running live, ability to take sort of direct self-referrals, etc. into it. I have to say, I think it looks really good. I think the material that's been put together and the background info that sits alongside it I'm just really conscious that so many people on this board in particular and predecessor boards had such a big hand over such a long period of time in getting that over line and getting it away, and the fact that it's kind of up, running, live and operational in the midst of everything else we're covering on today's agenda. I didn't want the moment to pass without acknowledging that, and in particular without paying tribute to people like yourself, Stuart, Mallet and others who bear such a huge part of their working life and careers getting us to that stage. We'll all watch with interest how it unfolds and supports our population, but really good celebratory moment, so thank you and well done.
Absolutely, thank you. Julie.
Thanks, Joe. It's just picking up on the point that Philip raised. Philip, we're aware of that, and we are actually dealing with. We've had a couple of inquiries. So if you leave that, you don't need to email Lucy. It's already been picked up, and we'll be in touch.
Thank you. Thank you for updating us, Julie. Much appreciated. So if there are no other queries with regard to this item, I'm going to move on to the next item on the agenda. So that is the approach to healthy weight, a particularly timely moment to do this, particularly with the increased weight and BMI increasing the risk from a COVID sequelae point of view. So this is a really good time to be talking about weight, and many have put on a little extra during lockdown. So over to you, Lucy.
Thank you. And again, I'll take the report as read, but this is a really exciting approach. It's an approach that was developed by Public Health England and piloted a couple of years ago. And the feedback and the outcomes have been really good. So it's something we wanted to adopt locally. So a whole systems approach to obesity is basically sort of what it says on the tin. We're wanting to make sure that the whole system is involved in addressing the causative factors of being overweight or an unhealthy weight. So you can see, I think there's a very simple infographic that just demonstrates all of the partners that would be involved in this approach. We've already had our sort of first major engagement meeting, which obviously was all virtual because of the circumstances, but you can start to see mapped out in all of the boxes in figure 1 that we've got engagement with a wide range of partners. We're trying to make sure that we're supporting any area that comes into regular contact with people who may be interested in addressing some of their issues around their weight, to provide them with the knowledge and information to do so. So we've got online services, we've recommissioned our weight management services, so it's not just face-to-face, people can now access support online. We've got that provided by sort of more culturally specific and diverse providers. We've got schools involved. We've obviously got our campaign about the roadmap to health as part of the coming out of the roadmap to COVID as well. So like you say, picking up on some of the things that people may have found have become an unhealthy habit while they've been in lockdown. But as you say, quite rightly, also recognising that being overweight is a significant risk factor for COVID itself, but also a number of other issues around cardiovascular disease, diabetes, etc. So it's really starting to make sure that we're using the power and the engagement of all settings, including businesses, as I said, education settings, employers, to make sure that we have got similar messages and information being provided at all of the best and most available, most often sort of accessed opportunities. One of the things that we're really keen to do is work with things like our local supermarket chains as well, so that we can look at sort of purchasing habits, how we might be able to provide promotions that actually emphasize and focus on healthier foods rather than sort of the chocolate near the checkouts and those kinds of things that have been habitual, and also just continuing to develop our policy work. So we have adopted a very similar approach to planning applications for fast food chains and things like that we have done previously with alcohol licensing applications. So looking at the evidence of harm associated with fast food outlets, and we've successfully indeed managed to change the provision that would have been near a school where we have a significant number of pupils who are an unhealthy weight. So just being able to sort of attack the weight issue locally from all sides has been really important. We're very, very grateful for support from partners like Northamptonshire Sport, again as well, who are tying the work that we do in with their policy and programmes too. So I'll stop there. I could go on about this for a long time. As you can tell, it's very exciting, and we've had huge buy-in. People really, really pleased to get involved and play their part. But I'm happy to take any questions.
Thank you. Ange.
Yeah, Lucy, I've been asking about this for a long time, so it's a great paper. I'd be really interested in the sustainable food section in terms of, because obviously there's some areas that have done things where they have like fridges where people can put food in, you know, so if I've got extra and I know I'm going to waste it, you mean, obviously you've got to have governance around it, but there's some areas in the country where they have fridges where people can go to, and obviously some supermarkets are much better than others in putting healthier snacks near the tills than others are. You know the ones I mean. Some of the more supermarkets that are more on the basic level, you know, as you go in, the fruit and veg is there ready for you. Some of the supermarkets, they're far away, aren't they? Because they're encouraging you to buy the more expensive options. I'm just wondering how we're going to tie it in with those families who are really economically challenged, and how we can encourage things like, as well as food banks, but also minimising any waste whatsoever. So I'm sure it's on your radar. It's just and I've alluded to it in the paper. I'm just wondering, is that something next steps?
Yeah, absolutely. So you've seen that West Northants have obviously already got their programme up and running, and North Northants are looking to do something similar. And you know, we know that there's a significant correlation between deprivation, so people who have the least money to spend on healthy food, and obesity. So, you know, we know that there's a lot of education that we need to do, but also, like you say, making healthier food more available. Now, there's a range of opportunities to do that, as you've just alluded to. We haven't looked at the fridge type option that you've suggested, but we certainly have already got a plan from a point of view of making sure that supermarkets, etc., minimise their waste, that we've got food banks, etc., who can therefore maximise the opportunity. So it's just bringing those partners together where it makes sense to, and then also just making sure that they are as accessible as possible to the people who need them the most. Because again, people aren't going to travel long distances to access something when they could buy something cheap on their doorstep. So it is going to be a very long-term plan, as we've alluded to as well in the paper, but it is something that we're keen to make sure that we absolutely, I'll say it, and very unashamedly, you know, exploit all of the opportunities that it presents.
Thank you. Will.
Yeah, thank you, Joe, and thank you, Lucy. Great report, really important subject, and of course plays into the wider determinants of health, doesn't it, and the system approach, as the paper articulates so well. Apologies, Lucy, if I should know the answer to this. My fault if I should and I don't. How are you taking this forward with the with our health and well-being boards, and in the joined up system approach, and also a sort of subset question to that? You see in section 6 the future plans. I think it's on page 58 of the pack, but there's a half a dozen dots on the future plans for 21-22. The second last one says keen to identify senior management and political champions in the 2 unitaries, which I think is a great idea. I just wondered if that might be something that could be picked up through the Health and Wellbeing Board as well, so that there's clearly political and executive championing of the agenda. Anyway, just some thoughts.
Yeah, thank you, Will. So we've literally just started to have the conversation about, does this go to the Health and Wellbeing Board? Obviously, the Health and Wellbeing Boards, we're trying to make sure that they're not sort of overwhelmed with regard to, they've got a lot of transition work to do alongside the CCG around the ICS. So it's making sure that obviously their agenda remains as strategic as it needs to, but has some of this detail in it. So we have approached the chairs to ask if this paper could also go there. As you say, there's a lot of place-based delivery that we would need in order for this to be effective. It not going to Health and Wellbeing Boards, if that indeed is the decisions of the chairs, doesn't mean that we won't obviously end up taking the work forward. We will be briefing both of our portfolio holders in the North and the West, and indeed, as you will have seen through the paper, we've got a lot of other directorates within both of the councils already involved in the work. So we are keen to make sure we've got that political leadership, and we will have it naturally through our portfolio holders, but I'm just waiting for the chair's views on whether it goes to the Health and Wellbeing Boards or not.
Thank you. Philip.
Yeah, Lucy, you mentioned the previous pilots which the work had been based on, and we are moving across to outcomes-based commissioning. And I was just wondering, within this, how you are going to measure the effectiveness of the interventions and whether we are, spending the taxpayers' pound appropriately.
So from a point of view of the directly commissioned weight management services, obviously that's a lot easier to measure, and there are targets that are set by Public Health England around percentage body weight loss and how well that's sustained over time. So those are very clear cut, and the contracts obviously are awarded according to the success rate. From a point of view of things like linking this in with social prescribing, again, this is part of what we know a lot of people will be looking to address as part of social prescribing, and those outcomes are also very much focused on people's feeling of well-being, which is less directly associated with perhaps a weight loss. But I think we all know that when we're a healthier weight, when we can move more and do more, and we feel better about ourselves. So there is an element of well-being measurement that comes into some of these services, and the services that are linked with the delivery as well. From a point of view of things like engagement with partners, obviously that's more difficult to measure. But I think fundamentally, obviously, when we look at the percentage of our population that's overweight, we need to be looking at setting ourselves a target over time. As I said, this isn't a quick win overnight, but over time that demonstrates that people understand what it is to eat well, to eat healthily, and to have a healthy weight. And that obviously will be measured by, at a population level, the number of our population that are overweight or obese. We would also, therefore, we would see a resultant reduction in things like type 2 diabetes, cardiovascular disease, potential, there are cancers associated with being obese as well. So you would also see a resultant reduction over time, again, I'll stress, in some of those diseases where weight does obviously bear a point from a point of view of clinical risk. So there are some very tangible outcomes we can measure, some shorter term, some longer term, but we obviously have the public health outcomes framework that will help guide us there.
Thank you. And just one final comment from me. I think the link with social prescribers is obvious, but probably not explicit within the paper. And I think also as sources of referral. So a lot of our social prescribers are not just dealing with well-being in the more generic sense, and are actually people who may well motivate people to make a change in their lives. So I would like to see a slightly more explicit reference to social prescribing and the link with that.
Can I just add, though, that obviously we've got 4 target cohorts very specifically for social prescribing. We know that those target cohorts, when they speak to their wellbeing advisor, their link worker, are quite likely to identify weight loss as potentially one of their ambitions or goals. So this is, social prescribing is not meant to be a weight loss service. And that's why it's not explicit, but we recognise that people with long-term conditions or who are socially isolated or who have mental health issues quite often do also have a desire to lose weight. So it's a kind of a secondary outcome to social prescribing. That's why we didn't want to confuse the referral reasons.
No, that's really helpful. Thank you. I'm going to push that in every place that I see that. So that's really helpful. Thank you. That's been a really helpful set of items, particularly looking at wellbeing and health promotion. And I think it's very much the direction of travel for us as a system moving forwards, and to make sure that there is much more focus on prevention, as well as dealing with those who are ill or believe themselves to be ill at any particular time. I'm going to move on with item 12. So this is the Governing Body Assurance Framework, and this is over to you, Stuart.
Thanks, Chair. So again, I'll assume the paper's read, and I'll just bring out highlights. Obviously, we stood down reporting of the Governing Body Assurance Framework during the COVID. We have now agreed we would stand that back up from June. It gives you assurance of what we've done since that period of time, where it's gone through the corporate management team a couple of times, it's gone through the Audit and Risk Committee, been refined, and is now here fully populated with 8 risks highlighted, which 3 are red, 4 amber, and 1 is yellow. And I'll take in at that point that is here to be noted and give assurance. Take any questions, Chair.
Before we start, I believe there's one typographic error on the front sheet in item 6, which I believe is population health management rather than public health management. Am I correct in my assumption? Sorry, I did read the papers. Any other comments on this? I am delighted to see this back, not because I want to see risk, but because I think we need to be absolutely cognizant of what is going on. This is a situation where there are significant risks within our system and our organisation, and I think it's really important that we are cited on them at this point. So it's not that I'm pleased to see the risk, but I'm pleased to see that we are cited on them, and I think this is absolutely the right time to be doing this. Any questions or queries? Toby.
Thanks, Joe. Two comments. Building on your reflection now on seeing this coming back. The first is just to say, and I appreciate some people in audit will be aware of this and have seen sight of it during its development, but I think Emma would confirm that this has been the product of a really extensive set of CMT discussions from an exec team point of view. This is not a collation of things that have come from separate parts of the organisation. We've spent literally kind of an hour at a time in some big chunks of debate as an exec team about the levels of risk that we're running organisationally and as a system. And that leads to the second point really, Chair, which is we've really struggled in places to be able to differentiate between and draw a distinction between organisational risk and system risk. And in a sense, it's not at all surprising given the trajectory we're on over the next 8 months in moving towards ICS arrangements. And so if you look at some of the key risks here, particularly things like workforce, actually the critical risk there is not an NHS, a CCG internal workforce issue primarily. That's not to say that we don't have capacity issues, but in the main we're talking here about provider workforce, whether that's community services, acute, primary care, and actually the care sector as well, having been out this morning meeting with the chief executive of one of our local care providers and the challenges they're facing. And you only have to look today nationally at the issues around vacancy rates across the economy in general to see the kind of recruitment and workforce challenges we've got. So it was really just to acknowledge that in the end we concluded actually the distinction didn't really matter that much. What we needed to do was capture the things that rightly this board, as well as probably the Health and Care Partnership Board, should be anxious about and cited on in terms of levels of risk we're running. And trying to get too purist in the distinction between those two things was not the really material thing. It was more important to capture the right risk there. But it does mean that when you start to work through the risk register to the right-hand side of things, you see actions and other parts that very much become system response actions into all of that. But I'm content that what we have in front of us is a good reflection of the level of risk, which is clearly significant that we're running in different parts of the system. And the response to that is in many cases quite multi-agency and stranded, but that feels okay and appropriate to me at the moment. The critical thing is visibility. Thanks, Joe.
Agree completely. Better to be mentioned in two places than not to be mentioned at all. Absolutely support that approach. Will.
Yeah, thanks, Joe. And Toby might have answered my question actually, but do say if you think you have, Toby. I'm just wondering whether on a RAG rating like this, post mitigation, would we not normally expect possibly most, but at least some of the risks to be green rated post mitigation? Does the fact that none of them are, does that reflect the scoring system, or does it reflect a need, do you think, to put more effort into mitigation to get post mitigations to green, or am I misinterpreting it?
Toby, yep.
Do I or Stuart? I don't. Sorry, actually, Stuart probably ought to let us director lead for this respond first, and then I might chip in. Will. Stuart?
Okay, over to you, Stuart.
Yeah, so if you look at some of the scoring, the post is down to 6. We've gone down as yellow rather than green. So there's partly their answer, Will. But yeah, some of them though, in reality, because of the very nature of them, they was probably at this moment in time never going to get to that green because of the fluidity of them. So you've got to, yes, some will go green or low scored, but some will never get to that as well, because of the nature of the risk. It'll always be there.
Okay, Toby, did you want to add anything else to that?
I just echo what Stuart said. I mean, Will, there's lots of risks that we capture through our various registers that are green and that kind of run in that way. What we lift out here, obviously, are the big material difficult things that don't kind of fall into that territory. And we did have a really frank conversation from an exec team point of view about how realistic you're right. If you get the kind of risk management handbook out, it will say actually we ought to be aiming to a target position that brings those things down to a level which is lower than that. I think our collective reality check on some of these was that unfortunately isn't the world we're in at the moment, but we need to do everything we can to bring those scores down, which is why they all move in the right direction, but some of them still don't end up, even if all those things fall in place. And that simply reflects some of the challenges that we know we're going to work through over the next 8 months.
Thank you. Andrew.
I note quality is of a major concern, and I think there are some discussions in the private section. But for me, it feels that quality is increasing concern. So, A, am I right in that? And B, if I am, is it COVID and change related? Is it structurally related, or is it a legacy issue that has been around for some time? So, I'm not suggesting that things are in a terrible state, but it does feel that it's becoming increasingly an issue at the moment.
Ange, do you want to briefly comment? Yeah. Obviously not to spoil the anticipation of the policy paper that's coming later.
No, but I think Andrew's right. I think one of the key things is, Andrew, and I've been raising for quite many months now, is workforce is a real issue, and actually workforce in social care is going to be a real risk to us as a system, because obviously we did get some great, amazing staff who came to work in social care during COVID, but some of them are now returning to their other roles. So we know that workforce is a big issue. So there is a bit of a legacy over from COVID, and that's not gone away, to be honest with you, Andrew. And everybody's looking for staff, whether it be in an acute hospital, mental health hospital, social care, care homes. It's absolutely across the board. And some of it isn't just clinical. It's all your other staff as well, your ancillary staff and all of that. And that has quite a knock-on effect, Andrew, in terms of quality and staff. And so I think we have got a handle on it, but by no means are we out of the woods in terms of workforce. It's a constant thing that we need to address all the time, Andrew, and that's a key thing that every organisation will say to you, because staff have worked continuously through the COVID period, and some staff obviously need to have holidays, or they've decided not to stay in those roles. But we'll come on to that later on, Andrew. But workforce, as Toby's already alluded to, I know myself, and working with my colleagues in social care, we talk about it all of the time. How can we keep staff in social care? Because if we don't have people in the community in social care, how can we discharge people from the hospitals? So everything has a knock-on effect, but workforce is a huge risk, not just for Northamptonshire, but nationally.
Thank you. That's helpful. So thank you for that item, much appreciated. The next item to move on to, speaking of people, workforce and what we're doing, is very logical. Go on to Stuart to talk about the corporate working arrangements.
Thank you, Chair. So again, I'll same the paper as read. This is to sort of approve for the next 4 months the committee arrangements for the CCG, and noting, as Toby has highlighted, the journey that we are going to be on. The reason for 4 months, obviously we need to start to think about what the ICS requirement will be. Therefore, in conjunction with this, we would be looking at least for 4 months of this, if not sooner, to bring some of them arrangements into place. So this paper shows that obviously the relevant chairs, the executives have all been, and again the corporate management have been all involved in this. And in essence, you'll see in table 2, in essence, how we would like to keep pretty much the arrangements as they are for the next 4 months, and look to approve that. Noting that if something changes, a guidance comes out, that we would try to take this necessary steps even sooner. But obviously we would bring something back.
Thank you. And noting obviously as well the direction of travel within the ICS and the arrangements there, which I think is helpful to put down in the paper at this point. I think that's useful. Graham.
Hi, yes, thanks, Joe. Thanks, Stuart. I really just wanted to support this. I think that good governance is really important to the CCG, but it has to be proportionate alongside, other initiatives and workload. And I think this has struck a reasonable balance going forward for the next period. So I'm happy to support that proposal.
Thank you. I mean, obviously, this is not a paper for formal voting. I think it is a direction of travel that is absolutely consistent with everything that we've done through the preceding year and a bit, and to try and make sure that things are working in the most appropriate fashion that we can make them. Thank you. So we're going to move on to the next item. This is the Stuart section of the agenda, mostly with the odd interruption. So we're going to move on to the finance report again. We're going to assume that paper's read. Stuart, tell us what else we need to know.
Thank you, Chair. So obviously reporting a good solid position that we are underspent in month 3 at 5.6, and that I should say this was versus a plan that we submitted of 1 million surplus at this time. But there are a couple of things to think about doing that. Obviously the ERF, the Elective Recovery Fund, was separate and as a memo item, it was not to be included in the plan. So that is at month 3 1.8 million. And we have had a benefit of year-end accrual in prescribing, and we are currently underspending on the running allowance. And what has happened since most probably writing and closing the ledger at month 3 is we have received extra funding from NHS England, relating obviously all the way back to April, which things we have budgeted for, so it just increases our surplus. And we have managed to get what I would agree historical disputes with Propco going back a number of years, which has given us a benefit as well. So that's now built into this. Therefore, at this moment in time, we are heading for halfway through the year, H1, a 9 million surplus, which is a very healthy sort of position. Obviously, within that, there is some benefits, things like the Elective Recovery Fund. So the proposal in this paper is to give the Elective board or the collaborative, whichever way we want to call it, indications that they should spend that, so obviously for patient care and for best use within the organisation and the systems. And obviously to note that we are still holding the contingency, and the proposal is that we would offer that to the system to help the other partner organisations in the second half of the year when we don't know what allocations and funding will be. So we'll be looking for the governing body to approve both of those as well. Thank you, Joe.
Thank you. So there are 3 elements to this paper. One is to note the position, but also to approve both the delegation of the funding to the Elective Care Board and also to the system to cover for deficits as well. So I think there are 2 elements to this, which I will take those together, but I think if we could put approve both, if there is only one that you approve, please suggest which one it is that you approve. But it is important that we thank you, Andrew, you have won the competition. I was going to ask if there was anything else anyone wanted to ask at this point. Okay, so if you are happy with that, and if you could put that in the chat. Philip, please mention your point.
Yes, so it is about allocating these funds to the Elective Care Board, and I was going to raise it later on when we look at the scorecard in terms of service delivery. And one of the particular problems we're experiencing in primary care is both referral to secondary care for appointments and obviously outcomes for patients. But one of the major things which is holding up service delivery from primary care at the present time is access to diagnostics. And so for me, it raises a real question about whether we do have sufficient access to diagnostics at the present time, and whether transferring the funding to that board would actually achieve that an improved outcome in that sort of way, or what we would be expecting when transferring these excess of resources to the Elective Care Board. I'd just like clarification on that, please.
Thank you. And I think it's probably it's an important point to make, and actually is related to a meeting that you and I are in immediately after the recovery and restoration of services. So I think that's a key point, which is probably worth holding, but Ellie may well have a comment on as well. Ellie?
Thanks, Joe. Philip, the allocation of the money to the Elective Care Board, we need to agree as an Elective Care Board what we're going to use that money for. So diagnostics, possibly community diagnostic house, but it could be a system PTL there. And when we walk through the paper later on this afternoon, you'll understand more about the priorities. So access and diagnostics is only one. What we need to decide is how we decide the decision-making framework around which priorities they are. What's happening at the moment is that when we're having conversations in our CCG and we're saying there's money available, we have system PTL business cases in the system that we can't fund. So we're saying we've got money, but we can't access it through the Elective Care Board. So what Stuart is describing is how the system leaders, including primary care, can use that money in the right way to transform the services, which will then actually reduce the waiting list and improve the access. So it's a full cycle of events. So I just want to give a broader context, and maybe we can explore that a bit more in the private section a little later on today.
And I've been personally ensuring that all aspects of our system, including general practice, are part of that conversation. So it is really, really important that everybody's involved with how that money is spent. It is public money. It needs to be spent wisely. Thank you. So I believe we have voted sufficiently, even though we haven't quite finished the conversation, but everybody has put that in the chat. Thank you. I'm also just reminded myself that just looking back on the papers that item 13 actually did need formal approval for the corporate working arrangements. So if I could take a liberty and just briefly pop back an item, if you could put 13 and approve for the new corporate working arrangements, we do actually need formal approval for that as well. Apologies for slightly messing up the agenda. I think we have sufficient. 2, 3, 4, 6. There we go. We have sufficient votes. Thank you very much, everybody. So we're going to move on with item 15 on the agenda. So this is the contracting and procurement report. Over to you, Sarah.
Thank you, Chair. Just a few highlights really from me to pull out from the report. Just in terms of guidance for this year, we are still awaiting the H2 planning and contracting guidance. We're told it should land mid-September. So this report is still referring largely to guidance that was issued in H1, although we're still expecting from a contracting point of view H2 to be largely consistent with H1 from an NHS point of view, certainly. There's a little bit of a focus on the independent sector in this report, so a need to we have had contracts in place, local contracts in place with the independent sector since the beginning of this financial year, but they were 6-month contracts. You'll remember that came here previously, so we will need a discussion. It's really just to flag that over the next 6 to 8 weeks in terms of independent sector contracting mechanism for H2. But again, the elective care board deeply embedded in the oversight of that conversation and what that activity and arrangements should look like. And then really just to flag in terms of detail, some of the contracting team activity and procurement team activity in particular, starting to work through the guidance that is starting to come out from an ICS point of view in terms of collaboratives, in terms of new models. So a focus for us as a team over the coming weeks, certainly in terms of how we start supporting the transition work streams from ICS point of view in particular. In terms of how we actually transact some of the things that we've been describing as a system for the past few months. I don't have anything else to add, I don't think, in terms of highlights from the report, but I'm happy to take questions on it, Jeff.
Thank you. Any comments or questions for Sarah on the contracting and procurement? I think you have satisfied them.
Excellent.
Thank you. So we're going to move through the agenda. We've now got a section on quality and safeguarding. Again, really important, something we've touched upon a couple of times on the agenda so far, and really important we have that focus. So we've got the terms of reference for quality and safeguarding, which require ratification. Stuart, is there anything you'd like to tell us?
No, I think it's pretty much incorporated in the paper, other than to note once ratified, we will include it in the handbook.
Thank you.
Questions, Chair?
Yep. Any questions, queries, comments? Toby.
Thanks, Joe. I think it's right that we do what Stuart's asking us to do and the paper asks us to do here today, but I think it's important to acknowledge that the ICS transition work and the NHCP discussions over recent months around quality and performance arrangements are actually starting to move in a direction of shaping up a clearer distinction between a quality safety risk and a committee set of arrangements and a focus on performance and delivery. And I was toying whether to make this point on this paper or the previous item, because actually the contracting element obviously so much lapses into delivery and performance as well. I think it's fair to say that NHCP to date locally has tended to focus more on the transformation and improvement agenda, the big system priority work streams, and has perhaps been less focused on some of the day-to-day operational delivery across a number of those kind of key delivery areas. My sense is from regional and national conversations, and I think rightly, is that the further out of the pandemic we hopefully continue to progress, the more of a focus we see coming back onto delivery of core constitutional and national standards, not just the obvious areas like elective activity, but some of the big delivery commitments around maternity, around mental health and LD, and a number of other really important areas. So the reason for kind of chipping into this bit of the conversation is to say I think it's right for us because we need to tidy up and update our arrangements here. But I think in quite short order we'll get into a system conversation, and there is a discussion on Thursday this week with the partnership board in development session mode, looking through the kind of 8 big deliverable priorities from an NHSE perspective regionally and nationally, taking stock of where we are as a system, and then giving some thought to, well, how are we actually maintaining oversight and governance and assurance across that set of arrangements? And I think that will further prompt this discussion about the need to establish something that's not a CCG internal thing, but something which is a system mechanism that brings our partners together for a conversation about where are we on those big delivery areas, how are we manage them in terms of leadership and plans moving forwards. So supportive of this, but noting that really, I guess, Joe, as context that I think will evolve quite rapidly alongside this as these arrangements are kind of signed off hopefully today. Thank you.
And obviously that was noted in the corporate working arrangements as well, which was absolutely key. So it's important to look at all of these together. Ange?
Yeah, just to pick up on what Toby said, because in actual fact, our system quality committee is going to go from bi-monthly to monthly. And also we will be looking to change the name of the quality committee. It's not for people to be concerned at the moment, just to say we've got to have those conversations, our next quality committee at the end of this month. But we will be going to monthly, as the CCG committee at the moment is bi-monthly. So just to explain that, those will complement in terms of timescales, and picking up on what Toby said, but he's covered everything already.
Thank you. So if you are happy to ratify the amendments to the terms of reference, if you could put the number 16 and ratify in the chat, that would be much appreciated. I think we have sufficient votes. Thank you very much, everybody. So much anticipated, we are moving on to the Integrated Quality and Performance Highlight Report. This has obviously been a labour of love that has been through various different iterations. It has an enormous quantity of data. Feedback has been very much appreciated, and I can see absolutely has been incorporated. Ange, do you want to go first? And is there anything that you particularly want to draw our attention to before we open that up for questions?
Yeah, thanks, Joe. And yeah, all comments that we've received, we keep adapting it because we are chasing perfection if we can finally get there. So just to bring to your attention, on page 12, you'll see that we've actually put some more performance data around IAPT and children and young people's mental health, the access standards. Now they're annual measures, but we will be looking at those monthly. So they've only just gone in to the report. Also, just to bring to your attention, I've checked again. There's still the national changes around, we've got KGH who have been part of that national pilot around A&E. Unfortunately, those national changes haven't took place yet. So again, I don't have performance data to give you because we haven't got that to share at the moment, Joe. And that's something I will keep cited on. I do keep asking just to assure the governing body, we do work very closely with our teams in KGH, and we are looking at performance, but they're not actually, they don't have to actually report formally on it at the moment because they're still part of that pilot. But we're hoping that that will change very, very soon. In terms of urgent care as well, still seeing very high levels of attendance, but that's being monitored through our SDEC channels and the urgent and emergency care, the SAGE teams. We work very closely with them, Joe, but we are seeing quite high levels of demand there. In terms of cancer, both for KGH and NGH, we're still not meeting the 62-day cancer standard. However, we have been exceeding the faster diagnostic standard, which is something to just be noted on, because that's really a successful piece of work there. The quality and safety team, obviously, we're working very closely with the trusts around any potential breaches, but we've not seen any harms to date. In terms of mental health, we have been reporting on our independent provider Broomhill, We are working extremely closely with this provider. We do have a quality improvement board in force, and our next meeting is on the 27th of August. We're working really closely with them. We have seen some improvements taking place, but obviously we've got to make sure that they are sustained. We communicate with Broomhill every day. We have safe today calls with them, and we're also working very closely with our local council, so that together we're working in a supportive approach, especially around safeguarding and also supporting them with all those quality improvement initiatives. So that is in terms of Broomhill. It's an ongoing situation, but we are in daily conversation with them, especially around workforce, in terms of how they're staffing their establishment. But like every organisation, it is a challenge. In terms of care homes, we're working extremely closely with our council colleagues, because I'm sure you are aware that there is a need for all staff to be vaccinated in care homes. Now, there's some significant dates that we need to be mindful of. The 16th of September is the last date for the first vaccination for staff, because it comes into force on the 11th of November. So as you can imagine, we're working very closely with our colleagues, the North and the West Councils, to support care homes to encourage staff to uptake the vaccination. In fact, our midwives from our CCG took part in an event to encourage staff to take the vaccine as soon as possible. We do predict we may lose staff because they do not want to get vaccinated. So that's something that we're working together through our care home board, just to keep sight on that, and also work with care homes so that they've got the communications that they need to work with staff to get them to get vaccinated. We also know that our colleagues, the CQC colleagues, they're now actively inspecting care homes in Northamptonshire. So we have been working with the local authority, and they've put in place some additional capacity to work with care homes to get them into a state of readiness, because COVID was a very difficult time for our care homes, and we really need to make sure that they're ready in all scenarios, so that if CQC do come to visit them, they're up to date with, for example, their policies and stuff like that, because obviously all eyes have been on caring for patients, and they may not have got their policies as up to date as they possibly could be. So we're working with them on that. On some really positive updates, our team's been working with care homes, and we've actually delivered a whole suite of training over July and August and September. We're going to do it in September. So we've been doing COVID debriefs. So we've done 4 sessions using a trained counsellor. We've had a couple of epilepsy workshops, 2 diabetes workshops, some care planning workshops, and also some end of life workshops as well. And we hope by having those in force as well, that's going to help our care homes to be in that state of readiness from now and forward. So Joe, I'm going to stop there in case there's any questions, and then obviously Sarah will take the performance section on from me. I think she's going to pass on the baton, unless you want me to stop for any questions.
No, I think what I'm going to do is to take Sarah's point next, because of the intimate relationship between quality and performance, which we've always talked about. So I'm actually going to bring in Sarah. It'll also give people a little bit more time to compose their questions in both the context of both those aspects. So Sarah, over to you, please.
Thanks, Joe. Just a couple of points really to add to what Andrew's described already. I think important to note, we're starting to see significant drivers of performance data from outside the borders of county now. So particularly for some of our significantly red areas, some of that isn't being driven by in-county providers, being driven by out-of-county providers, particularly when it comes to things like elective waits over 52 weeks. So just having some discussions about particularly how we get a better or tighter handle on performance management potentially of some of the associate contracts, which I think is just important to note. I think the only other thing really to say from my point of view is that we are continually iterating this information, and really goes back to the conversation we had about terms of reference previously, which is I think there is a need for us to look at performance differently at a system level. And therefore, what you see in front of you now will iterate and evolve over the coming months, so that we bring in, from a performance point of view, particularly drivers of performance in terms of the commissioning portfolios. What are some of the challenges, solutions to the performance we see, and how are we actively managing it, both on a day-to-day basis and from a commissioning point of view as we move forwards. I think really that's all I would add at this point. But like Anne's, happy to take questions if colleagues have any.
I'm going to take liberty of just making one comment to start with, that at the moment primary care only has general practice in it. I think it's useful to have a heading of primary care, because moving into the system context, obviously dentists, pharmacists, optom are going to appear within that, but noting at the moment we don't have all of primary care described because we're not responsible for the commissioning of those. And I think, as ever, to look at some of these figures, and we'll look at coloured arrows going up or down, just to be very mindful that those are people, and those are people who are struggling and who are having conversations with me and other clinicians across the system about what can I do? I can't possibly wait. How do I manage? And I think it's just very much important to be cognizant of the distress that is caused, sometimes clinical harm, but sometimes it is distress rather than clinical harm, and just to be mindful of that when we're looking at the figures on the page, which I'm sure everybody is. Graham.
Thanks, Jo, and thanks, Ange and Sarah. It's not the easiest read, this paper for July. You know, you used to summer things improving, and clearly it's a real mixed bag in terms of you know, certain things getting worse. I wondered, particularly Northampton General Hospital, you know, more downs than ups, elective, cancer, safety, C. diff, MRSA. Is there anything particular we should know about the situation there? And really, is it getting better in August, you know, as the COVID cases are sort of levelled off again? Are we likely to see a better result for August, or is it more of the same coming?
Ange, do you want to respond to that?
Yeah, I mean, what I would say is, Graham, is when there's any outbreak whatsoever, MRSA, C. diff, or anything like that, our team works with the organisation to actually do a bit of like track and trace. How did it happen? What lessons could be learned, you know, in terms of that. So there's actually a very thorough investigation that takes place around that, because obviously we have to report on those metrics. I'd like to say it's just maybe something that's a one-off, but I've got to say, Graham, we have listened to other nurses in the Midlands, and we are starting to see other infections coming forth. So I don't think NGH is anything. I don't think it's on its own, but it's something that we're taking very seriously. So our teams do that on a one-to-one basis in terms of each individual infection we look at. So, and we'll continue to do that. And if there is any trends, obviously we'll take it through public health as well. I think July and August has been a very difficult time. We did have to ride the waves of the pingdemic. I have to say, I think that's improved now. I think there was a real challenge at times around that. I'm hoping, Graham, it's just a glitch, but it's just something that we will keep sighted on and work very closely with Sharon, the Director of Nursing, and also Matt Metcalf, who's the Medical Director as well. And we do also have our monthly meetings with NGH, and if need be, we have them more frequent. But we will keep sighted on that, Graham.
Thank you.
Sarah?
Yeah, I think, Jo, I just want to add a little bit, particularly from an elective point of view for NGH. So we're saying, Graham, I think that although RTT 18-week performance has deteriorated very slightly for NGH within month, 52-week performance has improved. So they've been targeting the longest waiter, and also not to suggest that the performance is at a level that any of us would want it to be. But NGH's RTT 18-week performance currently exceeds KGH and exceeds all our out-of-county providers as well. So while it has suffered slightly in month, it's still the highest in the system in terms of 18 weeks. And the priority we can see from a performance point of view has been reducing 52-week waiters in between then and now, and that's obviously shown really positive performance. So really, the kind of point of outlining that is it's all balanced at the moment. We know we've got constrained capacity. Constrained capacity is going to continue for some months yet, and we'll pick that up, I suspect, as part of some of the conversations we're going to have later in the day. But I thought just important for balance to say that the ups and downs don't necessarily give you the whole picture in terms of overall system context. Thank you.
And it's probably also worth mentioning at this point that system clinical leaders, medical nursing and allied health professionals are working across the system to balance those needs, to look at where there are areas of pressure, and that's something that has been helpful as far as the messaging out to the wider workforce is concerned, to make sure that we can give people constructive advice about how to make the limited capacity that we have within the system, how to make it work best for our population and minimise risk. Ali.
So just to add to that, we are working better as a system, but we've got a long way to go. So some of the mitigation you're describing, Graham, is about the two acute hospitals working together closer, and then the impact on primary care and the independent sector. We will go into detail later. So that variation, we do need to settle it down, and it's just exposing where we're at, and visibility of that whole system working limited currently.
And just for completeness, obviously, the other element within that is obviously the community services, which are absolutely key from the point of view of making sure that only those patients who are appropriate to be in hospital beds are there. And it is really key that we make sure that community services are part of this, particularly intermediate care teams, but also other community services as well. So it is a whole system approach together with social care as well. So it is a complex situation, but and one that we continue to be concerned about, but obviously need to monitor that. Will.
Yeah, thanks, Jo. On the first slide, which is on page 109 of the pack, I'm looking at the MRSA and C. diff numbers, and well, using MRSA as an example, just because on slide page 109, it's down with this month and last month as 0, but when I look at the slide on page 111 for NGH, there's a positive MRSA for the current month, and I wonder, am I misunderstanding something in the data here, or is there something that needs a closer look at? But I do understand what Ange was saying, by the way. I thought that Graham was going to ask exactly my question. I took my hand down, but it is MRSA and C. diff are popping up all over the place now, aren't they? And forecasting the future is always a challenge for a board, isn't it, that we should look at, and I wonder if we should be worried about the autumn with MRSA, C. diff, and then pandemic challenges as well, whether life is going to get tough if we don't get this under control, as it were. I'm not saying it's out of control, by the way, you know what I mean.
Yep.
Yeah.
Ange, do you want to respond to that?
Yeah, just coming back on that, because it's something as regional chief nurses we've been talking about, is C. diff and MRSA, and also CPA, the infection around urine, that's starting to pop up as well. One of the things we're really focusing on is the cleaning campaign. During COVID, there was an amazing cleaning campaign that all trusts got involved in. And I think, if anything, we just need to really force that home, if I'm honest with you. Well, it's a just hot discussion at the moment between all directors of nursing to make sure that, because we got to a point where we weren't seeing any C. diffs or any MRSA at all. It was really under control, but they are starting to slip back in again, and that's something that we've got an IPC team. So working with what we've got now, we've mapped all our IPC capacity within Northamptonshire. I'm yet just to present it back to the governing body, but there's a lot of capacity across the system of people leading in IPC roles. So one of the conversations now is, how do we focus on everything, not just COVID, but how do we work together to stamp out the emergence of MRSA and C. diff? And that's also a conversation I'm having. Every 2 weeks I meet with all the DIPSIs. So just to assure you, Will, we can see it. We know it's there. It's something that's being monitored very closely by NHS England. And hopefully when we report back, I can give you a better understanding of what the trusts are doing now.
Thank you. Lucy.
I didn't know whether to mention it earlier, but I will. So we do also have a multi-agency health protection board, where we've obviously got a number of the representatives that Angela's just alluded to, but we also have the microbiologists, we have Public Health England, we have Health Education, NHS England, etc. So again, we look at what the epidemiology is of all of the various infectious diseases. The thing that we particularly focus on is whether they're nosocomial or not, so whether they're picked up in hospital. That obviously is more of a reflection of a quality issue, whereas something like C. diff obviously can end up occurring just because of somebody's combination of antibiotics, for example. So it's more of a therapy-related antibiotic-associated diarrhea. And therefore, it's trying to make sure that we're differentiating between what is a quality issue and something that we have more control over versus something that is unfortunately an outcome of a particular treatment or therapy. And therefore, although we'd want to avoid it at whatever cost, there's less direct control. I think the other thing to note, Will, is just that I get a weekly report from Public Health England where I can see the infectious disease, a notifiable disease list for all of the areas in the East Midlands, and they are going back up. So we haven't had, for example, reports of norovirus outbreaks on wards across the region for months and months. This month, there are 2, not in Northamptonshire, but it is just noteworthy that obviously as people are mixing more both within the hospital, because the infection prevention and control, and distancing arrangements are not as stringent because they're not required to be, and because from a capacity perspective we can't afford them to be if they're not a requirement, but also people mixing outside again, we will see a significant increase in those sort of community acquired infectious diseases.
Thank you. Did you need to come back into the conversation, Will, or is it a legacy hand?
Yes, no, if I may, Jo, just to say
yes,
thank you to Ange and to Lucy for those comments, and really helpful. No need to do it now, Ange, if it's not easy, but just would you perhaps outside the meeting drop me an email about that slide 109 and why the MRSA on slide 109 is 0, whereas it's not on slide 111. So I'll leave, but no need to take time on it now, Jo.
Although I believe Sarah might be about to answer your question.
Oh.
Unfortunately, Chair, I wasn't actually going to answer the question.
Okay, fair enough. We will answer your question, Will.
What I was going to say, Will, is I'll pick the data issue up with the performance team. I think it's a transposition error between the two things. So the NGH position is correct, and therefore I think the summary dashboard is slightly wrong. But I'll pick that up outside the meeting. I will just drop you a note and round to the rest of governing body as well, just to make sure that the correct position is understood. And apologies for that.
Many thank you, but you do win an Eagle Eyes award for that one, so it is much appreciated, and thank you to everybody who picks up these points in the papers. It is really important that the information we share and display is accurate, so thank you very much. So the next item that we have on the agenda is item 18, which is the Public Sector Equality Duty report. This is, just to remind you, will be a paper for us to ratify. We, I believe, have Barry O'Donovan joining us, who I can't see on screen, but I'm assuming is here. Barry, are you here, Barry?
Join us, Chair, at 3:15, which is the time.
Hello.
I think
Barry. Oh, there, Barry.
That was good timing. I joined just as you mentioned my name.
Marvellous. We have Barry. You are extremely welcome. Thank you for joining us. Thank you for flexibility on timings. I suspect that Emma had a small part to do with that, and I'm grateful for her calling you a wee bit early. So this is obviously the much anticipated annual report. We have obviously read it. Tell us which bits we should particularly be looking at, and anything else that you would like to share with the governing body.
So yeah, just to say, this is an annual report which normally gets published the end of March. This year, due to COVID, the publication date is the 5th of October. So this is the draft, subject to any comments or amendments that will be published. I think a major section of the report is clinical improvements related to the equality objectives. And this mainly focuses on care homes, learning disability, and cancer. There's another significant section, which is the radical change in approach we've all had due to COVID, due to vaccinations, and there's some excellent examples of how the CCG and providers did things differently in that period. And I think the final section then is around staff equality and sort of inclusion initiatives. And obviously I know we're going to come on to later in the year the RES and the WDES reports. So there is something in here on this, and then that they would take them a step further. So I'll stop there for any questions or comments.
Thank you. Very much an interesting report, covers all sorts of interesting areas. And as you said, this has been an opportunity for us as a nation to reset our views in this area. So I think if nothing else good comes out of COVID, it is very much that this conversation is live and is real. Any comments or queries? Sarah?
Just an addition, Joe, if I can. So the report mentions towards the end our workforce race equality standard, our workforce disability equality standard for 2021. Just worth saying that Barry and I went to a really good event earlier in the day in terms of engagement around the data and action planning for the current year. So really just to reflect to governing body that whilst this report is at a point in time, this is a continually evolving and moving agenda. And we had a number of CCG staff with us earlier in the day talking about how we continue to make progress on a number of the kind of really important challenges, and building on some of the improvements that I think this report is really vocalises really well. So I just want to add that in terms of a current view from today. Thank you.
Thank you, Sarah. I think I have one small and minor point, which is on page 116 of the pack and page 30. There was a requirement to recruit a lay member to our board from the Black community, which is at the moment we don't have a vacancy, and I don't particularly want to get rid of any of my current NEDs. My concern is it could be read as a recommendation to lose our extremely valued colleagues that we have on the board, while recognising the importance of diversity. And also the question why it had to be a Black community member rather than somebody from Asian or other ethnic minorities or any of the other protected characteristics. I wasn't sure why it had to particularly be that one. But my main concern was obviously to eject trusted colleagues in order to choose somebody preferentially of one community. I wasn't quite sure why that one was there, and I didn't know if you were able to comment on that.
I can, Joe, if that's appropriate. So bear in mind this is the action plan from last year, so not the current one. But just to say, I don't think there was anything intent in the action plan about replacement of the current lay membership. More that if and when a vacancy did arise, that we took some positive action around recruitment in terms of targeted communities. The reason for the specific targeting there was due to the percentage underrepresentation we had across the staff body, in particularly that community. But that won't necessarily be the case this time around because the data has moved. So I think probably noted that what we'll do as we move forward is just try to make where it's possible for that to be slightly rounder for it to be so. But the reason that the Black community was specifically noted in there was because it was the most underrepresented at the point that the data was put together across the CCG staff base.
I think that background is helpful, but and also helpful to recognise that we have no plans to lose valued colleagues at this point. Please, thank you, Andrew.
Thank you for that reassurance. Just a quickie, and I think it's all really good stuff, going in a really good direction. Recognise all the hard work that's gone on. The thing for me is there any sort of data around the county construct from an ethnicity point of view? Because actually, it makes sense to represent our patients, our customers, as it were, and that for me is the real measure of success, if we are truly representing our patient diversity, and maybe that's a great way to build a target bottom up.
Andrew, thanks. Yeah, funny you should say that. The session we held today, I embedded representation of BAME in the RES report, the race one, and of disability in the WDES one. So I took those from the latest JSNA data I could get. So we are now sort of using that population representation as a benchmark to measure things.
Thank you. I think that's really helpful. Toby.
Just to make a link looking forward, I think particularly the conversation about kind of representation, board compositions and so on, an obvious comment to make, but we will, as a county over the next few months, under Naomi's leadership as our independent designate chair, be going through a process of recruiting and appointing into a whole series of different roles, lay and exec and non-exec, etc., as part of that process. So an obvious opportunity, I guess, Sarah, to link some of the themes from here into the work that's been taken forward through the transition programme and some of those work streams about setup of new organisation, because whilst I entirely echo and support Joe's view of not wanting to create vacancies and destabilise things during the transition, we're going to go through a period and a process which will have mechanisms that do allow us rightly to emphasise some of those aspects. I also just wanted to add my kind of thanks actually to Barry, the team and others who've been involved in this, because I think this is a really good reflection of the depth and the breadth of some of the work that's been underway over the last 12 months on this, so it's so good to see it coming through here. Thanks, Joe.
Thank you. Lucy.
So I was going to actually reflect on a couple of things that people have already picked up on about the opportunity for us to look at the board more proactively as the ICS is created. Barry's also touched on the fact that obviously we do have data available, and my recommendation absolutely and my support would be that our board, and in fact our whole staff body, not just our board, is actually reflective of the demographic that we serve, and that goes for a number of protected characteristics, not just ethnicity as well. So I'm happy to support sort of doing analysis around that in any way, shape or form that would be useful.
Thank you. Absolutely, really helpful. Ange.
Yeah, I just want to pick up on just something Andrew's just said, because I think when we think of BAME, we think of people from maybe a black minority sector, when in actual fact we've got lots and lots of people from Eastern Europe who've settled in Northamptonshire. They live here, their children, and it is about that reflection. So I think sometimes we forget about that, because maybe we may look at someone and think they're not from a minority, but in actual fact we've got lots of people from a Polish or European who've settled in Northamptonshire. So picking up on Andrew's point, I think it's really important that we embrace all the differences in Northamptonshire. So I just wanted to make that point, Joe, because I think sometimes we don't look at the right things sometimes, because we're fixated on looking at a particular thing that we miss the breadth. So because obviously we want people who are reflective, who are living in Northamptonshire, caring for people. So I just wanted to make that point, Joe, because it is really important.
Thank you. Sarah.
Thank you, Chair. Just a couple of things really to draw some of those threads together. I think the report shines a light on some of the really positive stuff that we've done in terms of reaching out, particularly in terms of health inequalities as part of vaccination programmes and various other things, reaching out to communities in our county that aren't necessarily well represented in all of our forums. And we've learned some lessons from that, and we talked about some of those this morning when we were talking about recruitment, how you reach necessarily communities, how you reach anybody that doesn't look at NHS jobs when they're looking for employment, and various other things. So I think there's some really good work in here, but there's also some lessons learned, and we can apply it both to recruitment as we move forward, also potentially to retention, I think, as well, but also really importantly in terms of the culture of the new organisation that we want to build, the valuing of all of those characteristics, as Lucy says, of which race is one. And so I think some lessons learned from this report, there are numerous, and we'll take them forward in terms of the action planning for the next round, which should start to come through governing body in September and October.
We look forward to it. Thank you. Bev.
Just a final point, not to prolong it, but when we do take the opportunity, or as either post turnover or we have a new structure, I hope we'll think about associate or apprentice non-exec roles. I'm working with another organisation at the moment who is struggling with getting the more diverse representation through the recruitment process, and that's because lots of people have not got experience and finding it hard to break through. And so thinking about that sort of, apprenticeship sort of associate role, so that people get those skills, and then when vacancies are available, they've already got some experience, I think is a really useful way of broadening our recruitment network.
Thank you. I think that's a really helpful suggestion. So thank you everybody for your comments. As ever, this is always a topic that people are interested in. I am delighted to have had this at the governing body today. So this is a report that we need to ratify, bearing in mind obviously the comments that have been made. So if you are happy to ratify this, if you could put the number 18 and the word ratify in the chat, I would be extremely grateful. Thank you. I believe we have enough to be forward on that. Thank you. And so the final, last but definitely not least, is Julie to present the primary care report, which obviously we have read, is of enormous public interest, depending on what publication and what social media you read. Over to you, Julie. Tell us what we need to know.
Thanks, Chair. So I'll take the paper as being read, and then just high level update in terms of the vaccination programme, which I'm pleased to say that our LVS sites, which obviously we had that took part for phase 1 and phase 2, the confirmation of them moving into phase 3. Letters are going out to our providers today, and we will have a good coverage across the county in terms of offering of the booster vaccines. That said, obviously this programme is due to start on the 6th of September, and we've also got the flu campaign as well going. So won't labour the point that's already been made, but obviously there is a lot of work that's going on in general practice and capacity, like with everywhere else, you know, workforce, etc. But really pleased that our primary care network and general practice have stepped into this space yet again to support obviously our population, to ensure that we are giving the third dose out along with flu to all our patients, to ensure that they are fully vaccinated and protect them from COVID and flu going forward. So I'll stop there. I have highlighted some other bits in the report, but happy to take any questions.
Thank you. And I'd like to give a particular thank, Julie, to you and your team for supporting the general practices in this county. The work has been amazing, but actually the amount of support that some have needed has also been considerable, and I think it is appreciated by the practices and appreciated by the populations that they serve as well. So I would very much like to thank you and your team.
Thank you, Jo, and I will pass that on.
Thank you. Toby.
Joey, it feels kind of wrong not to kind of on this agenda item acknowledge that whilst a huge amount of positive progress, the vaccination programme, tremendous success. If you look from a kind of county perspective at those areas in terms of public patient feedback, local politician feedback on behalf of their constituents and so on, the level, I think, as you referenced that slightly at the start of this item, Jo, of public interest and disquiet around access to general practice in some areas and in some places to varying degrees is very, very real at the moment. I know that Julie, the team are doing everything they can to work with practice and support, and my comments here are absolutely not about saying that there is something that general practice needs and should be doing differently. I think if anything, there's a kind of public messaging piece here around the kind of stretch roles that general practice are currently performing, the huge contribution they've made to the vaccination programme, the workforce challenges, just the same way as any other sector are facing at the same time as significant levels of demand, particularly as people come back into healthcare after a period where lots of people haven't necessarily presented in the way that we want them to do. So you've kind of got this really critical combination, I think it feels to me, of factors coming together at the moment to create really quite a very difficult situation and context for a lot of our member practices, but also for our public as well. We picked up with kind of comms teams around how we can do more to help in terms of kind of messaging, both about the services that are there that can be used differently and can be accessed differently. And I wasn't opening it up, Chair, for the intention of having a big debate necessarily here, because I appreciate we could very easily do so. But it just felt to me that given we're meeting in a public session here, and this is an agenda item around primary care and general practice, certainly what I'm seeing and sensing from some of the kind of inbox queries that come through to me personally on behalf of the organisation is a real level of just reflecting the challenge, both from a provider point of view and also from a public and an accessibility point of view. I don't think there's anything we need particularly to do here today, Jo, in opening that up, but it's really just to acknowledge that that's my sense of where we are as a county on some of those challenges and dynamics at the moment. Thanks, Jo.
And for those members of the public that are interested, there is obviously our Primary Care Commissioning Committee, and many of those meetings are in public and are visible to the public for those who may wish to know a little more. Amar.
Thank you for the report, Julie. It's duly noted, and thank you. But one particular item I want to bring some attention to is the primary care premises and estates update. And this is certainly very welcome, certainly from colleagues not just across my locality but across Northamptonshire, who are trying to accommodate, in their PCNs the significant increase in workforce, particularly around the ARS roles. So certainly look forward to that estates board update in September. So, but thank you for restarting that work, or at least for the estates group to restart that work. Thank you.
Thank you. Philip.
Just to thank Toby for your comments, actually, because the workload pressures in primary care are significant, and we're in a, fortunately in a well-resourced practice, really struggling to meet the expectations of our patients. Anything could be done to support that through public, maybe help or what we do, GPA. All of the partners are putting in extra sessions to try and provide extra consultations, yet we're still not able to meet the level of demand which we're facing. So it is really challenging at the present in terms of the resources that we need to the sort of service which you're talking about. And if that could be explained, it would take pressure particularly off our receptionists who are facing.
Thank you. And I just lost the signal ever so slightly at the end of that, but I think essentially what you were talking about was the increase in pressure and the increase in demand, which I think is important to recognise, not just for Northamptonshire but nationally. And obviously practices have been open all the way through, have been able to see people face to face throughout the pandemic, but there are times where the demand on the system exceeds the capacity that our population may want. That's not to make excuses, and absolutely to recognise the distress that the population feels as a result of that, and very much working together as a system to try and improve the situation. Any other comments that anybody would like to make on the primary care paper? Okay, so I think just to sum up the meeting that we've just had, I think there are 4 points that I would particularly like to make note of as a summary. I am delighted that we've been able to approve Bev Messenger as our wellbeing guardian. I think the wellbeing of people is extremely important. I'm delighted to see a system approach to weight management, particularly in the context to the post-COVID world, but even in the peri-COVID world, I think that is extremely important. I'm pleased to see the GBAF and the recognition of risk and the quantifying of risk across our system. And I'm pleased that we've been able to ratify and recognise all the work done towards the equality duty of the CCG, and look forward to seeing that developing moving forwards. So for those of you joining the next meeting, you have a 10-minute break. At this point, thank you very much for everybody for attending. For those of you who are not joining, please can we stop the recording?